Hello, I'm Dr. Miguel Reguero, and on behalf of CME Outfitters, I would like to thank you for joining us for today's educational activity titled Streamlining Preventive Health for Patients with IBD through Effective Care Models, Evidence-Based Guidelines, and Patient Engagement. This activity is brought to you by CME Outfitters, a best-in-class accredited provider of continuing education for clinicians across the globe. The target audience for this program are gastroenterologists, primary care physicians, nurse practitioners, physician assistants, nurses, and pharmacists who care for patients with inflammatory bowel disease. Part of meeting your MIPS requirements under the Quality Payment Program is participating in improvement activities. Today's program has been designed to meet those requirements. Your engagement in today's activity by answering polling questions, asking a question, and completing the evaluation and post-test are needed to complete the first step in the process. After today's program, incorporate these clinical improvements we discuss into your practice. And in 3 or 4 months, we'll send you a survey to complete, which will fulfill the data collection requirement. CME Outfitters will then send you confirmation of your participation, which you can submit to CMS. It's really that simple. As mentioned, I'm Dr. Miguel Reguero. I'm the chair of Department of Gastroenterology and Hepatology. I'm vice chair of the Digestive Disease and Surgery Institute and professor of medicine at the Lerner College of Medicine at the Cleveland Clinic in Ohio. Let me introduce our faculty who are joining me today. First, let me welcome Dr. Baljit Bal. Dr. Bal is the Vice Chair of the Department of Internal Medicine and Geriatrics at the Cleveland Clinic in Ohio. Also, let me introduce Dr. Gil Melmet. Dr. Melmet is the co-director of the Clinical Inflammatory Bowel Disease Division of Gastroenterology in the Department of Medicine at Cedars-Sinai Medical in Los Angeles, California. And finally, let me introduce Dr. Eva Sigathy. Dr. Sigathy is professor of psychiatry, medicine, and pediatrics. She's also the director of behavioral health within the Chief Medical and Scientific Office and co-director of the IBD Total Care Medical Home at the University of Pittsburgh Medical Center in Pennsylvania. So for this activity, I'd like to actually start by illustrating what's most important to the patient by playing an actual clip from one of my patients named Aaron. Aaron has ulcerative colitis. Let's hear what he has to say about IBD and how this has impacted his life. What's your future aspiration?
Normalization of life, getting back to the old me, pre-diagnosis or pre-disease identification. Just a better sense of wellness and health. I think that there's more to life than inside of a bathroom stall.
Great. Well, I think you're going to be well on your way. So I want to have a discussion with the three of you briefly. You know, we talk about these integrated care models and whether they be our own medical homes, medical centers, but also remembering that a lot of the people listening in today are physician colleagues and providers who are in the community. So I guess, Gil, let me start with you. What does a medical home mean to you? And maybe tell us a little bit about your program.
Sure, Miguel. Well, medical home, I think, can mean a lot of different things. Can mean an integrated financial model, which most of us do not have access to or participate in. But I think the concept of a medical home is one where we have opportunities to provide integrated, comprehensive care for our patients. And that could be in some places where that integrated care occurs all in one location within one set of 4 walls, like we have an opportunity to do at our program, or simply having the resources and the connections and the communications available and around and established that you can communicate effectively with other specialists taking care of your patients. So for example, at our program, we have a dietitian, we have a social worker that are embedded within our IBD program. We have psychiatry services, OBGYN services, and surgery services, which we can offer also within our IBD program. But we also interact with many other specialists. I think the concept of IBD has evolved such that we recognize that our patients have needs beyond what a traditional gastroenterologist can and should provide. We need help from some of our colleagues, and we need a good way to integratively provide provide that care for our patients.
Great. So this concept of whole patient care, whole person care, team, integrated care, one-stop shopping. So I love those concepts, and I think we're going to touch on a lot of these throughout the program. But also, as we go through the program, talk about how the community physician who maybe not has access to this can do this as well. So, Eva, moving from a gastroenterologist to the psychiatrist, and as I've often said before, the secret sauce in my estimation of any of these medical homes is really the psychologist, psychiatrist, social worker. So tell us, what does an integrated model mean to you?
So similar to Gil's program, we also, as part of an academic medical center, have a team approach co-located in the GI department. So at the GI visit, we also have a dietitian, a social worker, a psychiatrist, and then part of our medical neighborhood is so not in the clinic, but very coordinated with our model of care, is a colorectal surgeon as well as pain specialists. And I think, in addition to everything that Gil said, the coordination of the care, so having ways that we assess quickly and efficiently the whole patient, translate those findings into implementable treatment plans, and then track our progress longitudinally are also critical elements.
Great. So again, team-based, quick, one-stop shopping. So you've heard from two specialists now, the most important person, the primary care. And what's your thoughts, Baljit, in terms of a medical home, or what does this mean for you and the IBD patient specifically?
So as a primary care physician, whether you're part of an integrated health system or a community physician, you're likely not co-located with the specialty clinic as my colleagues are. And so from a distance, you need to be able to have that degree of communication and collaboration with your specialists, again, to continue to provide the entire spectrum of care for the patient.
Good. So thank you all, because I think this is going to be a great discussion. Next 55 minutes, we're going to have a lot of fun talking about what we do in our programs, but also for total care of the patient. So why a medical home? You heard a little bit about this, and I now want to switch to a clip on Dr. Majid Risk. Dr. Risk is a gastroenterologist, but is also the Associate Director of the Cleveland Clinic Accountable Care Organization. And hopefully this will help set the stage for what you're about to hear in terms of medical homes and these integrated models, and how we can align these goals in a value-based care system.
There is an impetus around diseases that are chronic, where there is no cure, but where we are managing as of right now, possibly from the cradle to the grave, to be able to find better ways of providing care for those patients, reducing the amount of disability. Some estimates are as high as 120,000 patients per year have disability because of inflammatory bowel disease, and improve the value proposition for healthcare organizations and for the U.S. economy in general.
Great. So I want to let our audience know that from the full interviews, and you heard some clips already, that these video clips we'll show today will also be featured in the Gastroenterology Digital Hub on the CME Outfitters website, and will also be included in the CME Outfitters podcast series. We know one of the key challenges for our patients with IBD is making sure they get their vaccinations. So this is our first learning objective as we come to the learning content part. Let's talk about vaccines, and let's make sure we provide clarity for our audience on appropriate vaccines and recent guidelines. Let's first engage all of you, our audience, and test your knowledge. You should see a question on your screen. Which vaccines should be administered to a 65-year-old female patient with inflammatory bowel disease who is starting immunosuppressive therapy? You should see the options in front of you. You can go ahead and submit your answer now, and we'll review them shortly. So Gil, let's now switch gears and talk from the kind of overall concept of medical home to the vaccine and the recommendations for IBD patients. So walk us through, what do vaccinations look like in IBD and maybe in your practice?
Sure, Miguel. Well, we actually do have some guidelines in this arena. This is relatively recent in our field to have guidelines for preventive health care. And I think it's part of the evolution of our understanding that there are a lot of complications associated with IBD, including the medications that we use. But there are strategies like vaccinations that can help us be proactive in preventing preventable complications. So when it comes to vaccinations, there are some very specific recommendations just to highlight real briefly. So for example, when it comes to influenza or the flu, the recommendation is universal. Everybody should get a flu shot, flu vaccination. When it comes to the specific kind of the flu vaccine, there is the shot, the vaccination, which is inactivated, as well as a live intranasal version. The live intranasal version should just be avoided in individuals who are on immunosuppressive therapy. But the flu shot is ubiquitous and really recommended to everybody. When it comes to pneumonia, there are 2 pneumonia vaccines, and we'll talk a little bit more about those in detail, that are available and are recommended for people with inflammatory bowel disease, specifically those who are on or going to start immunosuppressive therapies. In addition, a third very important infection is the shingles or herpes zoster, which is reactivation of the chickenpox virus. There are vaccines available to protect against the chickenpox and the zoster, which are available for individuals over the age of 50. When it comes to the chickenpox specifically, varicella vaccination, most adults in the United States have either had the chickenpox infection or have had the vaccination in childhood and are protected. But for those that aren't, it's important to identify these individuals and vaccinate them appropriately against varicella. And then finally, there are the usual vaccines that are recommended either on a public health basis, for example, like Tdap, tetanus toxoid, and pertussis, for which there have been recent outbreaks, as well as hepatitis A, hepatitis B, and importantly HPV, human papillomavirus, all of which are non-live vaccines and recommended according to the usual ACIP adult guidelines.
Great. So obviously many vaccines, it's important. We know preventing flu and pneumonia, which can actually lead to death. So we can't understate the importance of vaccines. Kind of getting into this concept of the live versus inactivated patients who are immunosuppressed. We don't want to give these live vaccines. So if we have to give a live vaccine, it'd be great to get that out of the way before starting therapy. So let's switch gears now and go to a short clip of my nurse practitioner, Ann Sullivan, and see how a nurse practitioner handles vaccination in our patients with IBD.
So with our IBD medical home, vaccinations are extremely important. The role the nurse practitioner plays, especially the role that I play, is predominantly educating on vaccines, counseling patients on vaccines, as well as administering vaccines in the clinic. It's extremely important to provide education to the patients as to why they need the vaccines as well. It's important to let them know that the vaccines will help with preventative health care, preventing influenza, preventing pneumonia, as well as shingles. Prior to our vaccine talk and prior starting to on immunosuppressants, we do screen for tuberculosis as well as hepatitis B, and then if they were to need a hepatitis B vaccine, I educate on that as well.
Great. So you've heard from a nurse practitioner who's embedded in a medical home how she gets involved in vaccinating our patients. But, you know, Baljit, let me hear from you. So primary care, vaccinations, obviously you've been doing this a lot longer than we have as specialists thinking about it. What's your approach and what do you think about vaccinations?
So obviously vaccines are tremendously important in a preventative way to prevent disability and disease for many of our patients, whether they be IBD patients or our general medical patients as a whole. You know, one of the most important things I think as a primary care physician is just to have a checklist. It can be electronic in your electronic medical record, it can be a piece of paper at the front of your chart, but just keeping a checklist of the vaccines that patient would need as they go through their life and their disease processes so that you can maintain that list and keep it up to date, not only just on the patient's annual preventative visit, but really at every visit they have in your office.
Good. So checklists are important. I like the fact you brought that up. In many industries, safety checklists in medicine, checklists with vaccinations, health maintenance. I think we're going to come back to this. Eva, let me get, you know, from a psychiatrist standpoint, I know you're probably not vaccinating against flu, although maybe you are because you're in a medical home. But, you know, there's a lot of barriers. There have been a lot, actually the measles outbreak, and a lot of concerns about vaccinations and our patients concerned about medicines in general. But vaccinations, how do you, there's some almost trauma concern around this. How do you approach that in terms of your medical home involvement?
It's critical to approach, and I think it's really listening fear is a big driver of lack of activation, across a lot of the things that we suggest to our patients. So really hearing your patients out, what are their concerns, and then taking the time in a collaborative way, shared decision making, to work with the patient and work them to a point of they're coming to the conclusions that the pros outweigh the cons and that this is critical for their health, and the dangers of not getting immunization outweigh whatever they are fearful about.
Right, so kind of the risk, the shared risk or shared decision, and talking about risk benefit and that type of thing. And then maybe Gil, I know you've done a lot of work in vaccines, you published on it, you're one of kind of the national leaders thinking about this and helping us as IBD physicians. What are your thoughts?
Yeah, well, I mean, as far as practical things that I do in the office, like you, I work with nurse practitioners who may have a visit set up just to address preventive health. We also have checklists embedded in our electronic record. But I think just to pick up on what Eva's saying, I think it's so important to engage our patients in conversation and to provide education as healthcare providers. They're hearing all sorts of stuff out there in the national media about vaccinations, misinformation and myths about the potential harm for vaccines, which we need to dispel as healthcare providers, as responsible healthcare providers. In addition to the fears that individuals may have because they're afraid that a vaccine may trigger their IBD, or they're afraid that they shouldn't get a vaccine because they're on immunosuppressive therapy, it's our role to actually educate. We also have to have conversations with our primary care providers. Whose responsibility is it to provide the education to patients and to actually move forward in administering the vaccines? And in different healthcare environments, it may be the healthcare provider from the primary care side, from the GI side. Having the conversation, having the communication, communicating through the electronic record is absolutely critical. But at the end of the day, the patients themselves needs to understand, because it's all about them, and providing them the education in a correct way, I think, is absolutely important and part of our role.
Right,
and I think it's also critical that this doesn't always happen in one visit. So
Right.
this might take multiple visits. I think the more it can be reinforced by all team members, all of these help move our patients along.
Yeah, so communicating with the patient, making sure they understand the risk and benefit. And I think that not being vaccinated is certainly probably even more of a risk. So let's go to our audience response question, our ARS question, and let's see how our audience did. Coming in now, and it looks like 7% chose A, influenza, HPV, and zoster, 11% B, influenza, HPV, pneumococcal. Most of you chose C, influenza, herpes zoster, and pneumococcal. Nobody chose D, which is MMR, herpes, and pneumococcal. 4% no vaccine should be administered. And then F, 13% not sure. So Gil, maybe let me get your feeling about that and the answers, with the majority saying influenza, pneumococcal, zoster. Some are still not sure. Actually, 4% say not vaccinate, despite what we just said. What are your thoughts?
So I'm glad to hear that our audience is educated. It sounds like most of the audience participants got the right answer, which is C. I think it's the points to make really are that the vaccines to think about, particularly in an older individual, would be pneumococcal influenza and zoster. For people who are younger, the HPV vaccine is indicated for men and for women. And the MMR vaccine, which nobody picked, that's a live virus vaccine. That's really something that we think about in childhood or in specific cases where adults may not have received those mandatory childhood vaccinations.
Great. So, and then let's move to the risk of influenza. So the risk of influenza in IBD versus non-IBD, what's the risk of influenza?
Well, that's a good question, and I think it's important to address this because people hear, okay, this is recommended, but it's important to take it a step further and be armed with why is it recommended. When it comes to influenza, there's studies that have shown, in looking at large administrative claims databases covering millions of lives, that the incidence of influenza is higher in people who have inflammatory bowel disease relative to people who don't, almost 50% higher. So our patients are at risk for getting the flu. But not only that, these studies have also taken it a step further and shown that not only are people more likely to get the flu if they have IBD, Crohn's or ulcerative colitis, but they're also more likely to be hospitalized if they do get the flu. So not only more likely to get the infection, but also more likely to have a complication of the infection that could result in a hospitalization. And whether that's a pneumonia that could be a result of the flu, or perhaps a trigger or flare of their IBD that may be a secondary outcome of having an infection, we're seeing that our patients are at risk for hospitalization even from the flu at a much higher rate than that in the general population. So that is the reason why we do recommend specifically, even though it's a universal recommendation, that our adult patients with IBD do get the flu shot.
So high risk, serious, they get hospitalized and potentially even death in some of these very bad patients. I'm going to ask Baljit a question in a minute, but I want to hear in terms of the effectiveness of the flu vaccine. How effective is this?
Well, this has been studied. There's probably been over 20 publications now from around the world looking at what happens when a patient with IBD gets a flu shot. And in general, having IBD itself doesn't impact the response to a flu shot. People still can develop antibodies, even though it's an immune-mediated condition. One might think that the immune system is off somehow and not responsive to vaccines. That's not true. Having IBD does not affect response. But being on certain medications, certain immunosuppressive therapies, particularly in combination with one another, may blunt that response a little bit. That being said, even on therapies such as immunosuppressives in combination, patients still do get some protection. And so it's important to recognize that and understand that even if somebody is on immunosuppressive therapies, they still will get protective immune titers from a flu shot, and that has been shown across multiple studies. And importantly, none of these studies have shown any significant adverse events beyond what is typically expected from the flu. In particular, a flare of IBD does not seem to be triggered by getting a vaccine.
Great, so flu shot, safe, it's effective, it works, it prevents. Baljit, you know, from a primary care standpoint, again, you probably give a lot of influenza shots. I know a lot of my patients that see you, you're giving these influenza shots. How do you kind of manage that in your office? How do you remember to do it? How are your patients getting it? Talk from a community standpoint, and maybe some tricks that you've done.
So come the month of September, it becomes the bane of our existence in primary care in the sense that literally every patient that walks in the door, we have the discussion about influenza vaccine, regardless of their medical conditions or overall general health. There may certainly be a few isolated conditions where we would not want to give a flu shot, but since it's an inactivated virus, that's quite rare. So virtually all of our patients will have that discussion with them, and we just make it part of our day-to-day workflow from probably early September until probably sometime towards the end of March.
Right, keeps you busy. Keeps
Absolutely.
your team busy
Keeps
too.
my team busy, yep.
So,
You know, if I could just add on,
Yeah.
one strategy that we've tried also that's been successful, we saw it in the organization and then we did our own mini version, is a health fair. The organization has a large community health fair where literally hundreds of people from the community are invited to come, and those just open to get flu shots. We've done mini health fairs just for IBD, where we will provide different vaccines, including the flu. This is done at flu season. We have some snacks out. The docs come, and the patients actually really enjoy being invited to an event where they can interact with their physicians in a less formal environment, receive some education around some of these preventive measures, and get their flu shot.
no, I love that idea. I mean, I think this patient-centeredness of also bringing the fair in a kind of less threatening environment. The physicians are there, probably show up on a weekend or after work. That's a great idea. I think that's kind of what we're hoping to achieve with this. So we talked about the flu. Now let's switch gears to pneumococcal pneumonia, another very serious infection in anybody, but certainly in IBD.
Yeah.
So Gil, let me hear a little bit about pneumococcal pneumonia and IBD.
Yeah, well, similar to influenza, the risk of pneumonia is higher in people with inflammatory bowel disease compared to people who don't. And this has also been shown in large administrative claims databases covering millions of people. So this has been well seen, and this is both in Crohn's disease and in ulcerative colitis, with almost a doubling of that risk. And pneumonia can be very serious. You mentioned death from the flu. Death from pneumonia can occur, and actually, especially in older people, can be a significant cause of death in our patients with inflammatory bowel disease, particularly those on immunosuppressive therapies. In this particular study that we're talking about, looking at this risk of pneumonia, not only is the risk of pneumonia higher in IBD, but there are specific medications that seem to increase this risk. And in particularly, interestingly enough, two of those medications that stand out are corticosteroids, and narcotics or opioid pain medications. And so we're learning that people on steroids and narcotics seem to be at particular risk, which might be a little bit counterintuitive because opioids are not necessarily immunosuppressive, but particularly at risk from getting pneumonia and dying from it.
So interesting. Pneumonia, another very serious disease that we have in our patients. We have to vaccinate against them. We'll come to, in a little bit, the opioid and pain part and some of the risk factors with the medicines. And Eva, I know you've done a lot of work in pain. But let's go back to pneumonia. And actually, Baljit, I'm curious to hear from you in terms of how should we vaccinate our patients? What's the guidelines? What's the strategy?
So as a primary care physician, mostly we're thinking about pneumococcal vaccination in our patients who are 65 and older, typically starting with the Prevnar 13 and then a year or more later completing the series with the pneumococcal Pneumovax 23 vaccine. However, in our IBD patients under 65, they may not technically be immunocompromised just on the basis of their disease, but many of them are going to end up on immunocompromising therapy to treat their disease. And so we really should vaccinate them proactively for pneumococcus. As opposed to the typical series, we'll typically start with Prevnar 13 first, and then at an interval of 8 weeks, we'll then administer the pneumococcal 23 vaccine to really move along and boost their immunity to pneumococcus.
Great. So pneumococcal pneumonia, it's fairly straightforward. I know it always gets us confused as gastroenterologists, but the dosing, the administration, you can build this into your EPIC system or your EMR,
Correct.
and there are guidelines for this. So thank you for outlining that. And Gil, you mentioned influenza, pneumococcal pneumonia. Now we move to zoster. Not something that we've traditionally thought about, but in the last 10 years, a lot of focus on shingles and how disruptive this is to quality of life, but how now it's impacting our patients, especially with some of our newer therapies. So talk to us about herpes zoster.
Yeah, so herpes zoster is an infection, as you say, where we've had increasing awareness over the last number of years, both because of studies that have looked at this in general populations, both in North America and in Europe, but also because medications that have come out seem to be associated with higher risks of shingles compared to people with IBD not on these medications. And so there are population-based studies, again, largely based on insurance claim registries, that have demonstrated a significantly increased risk of shingles in people with inflammatory bowel disease. And shingles is not just having the eruption of on your skin of the chickenpox virus, but shingles can be complicated. People on immunosuppressive therapies can end up being hospitalized. And then the incidence of post-herpetic neuralgia, of having lingering symptoms that can often take months to go away, can have a very significant impact on the quality of life for individuals impacted by this infection. And so recommendations have come out specifically around shingles and the shingles vaccination to vaccinate our patients with IBD. As early as 2008, we now have 2 shingles vaccines. One is a live version that's been around for a long time, and then a more recent non-live shingles vaccine. So as early as 2008, the CDC guidelines actually recommended shingles vaccination at that time with a non-live vaccine, even in patients who are on immunosuppressive therapy. So this is one of those exceptions where patients on immunosuppressive therapy were advised to get even the live shingles vaccine because the risk of shingles was so high and the impact of shingles was so morbid on these individuals. Subsequently, we now have a second vaccine, which is a non-live version. It's actually even more potent against protecting patients against the shingles, which is now recommended for patients, actually for everybody over the age of 50 as a universal recommendation. So this can be given on immunosuppressive therapy, not on immunosuppressive therapy as well. It is 2 doses. We don't really know the effects of this on people with IBD, but because we know that shingles can be so significant in this population, we are recommending that our patients receive it.
Yeah, and I think just to linger on that for a minute, the inactivated shingles vaccine that we now have available, 2 doses, 0 and then 2 months later, we worried initially that this might activate the immune system. So people get these kind of almost a little bit of a flu-like symptom after the second dose. The data are not at least showing yet that this activates IBD. So I think to stress the point you made, our patients should still get this. We shouldn't be scared of using this. They might get some achiness after especially the second dose, but that's important. So I want to hear from one of our patients now how they think we're doing in terms of vaccinations.
experience as a patient and also watching these conversations happening in my community, I think that gastroenterologists are not communicating with patients about the importance of receiving immunizations. I can't say that I've actually truly ever had a gastroenterologist tell me the importance of immunizations, tell me which ones to get, what schedule they should be on, and how they can affect me as a patient. I do not think that most GIs are talking to patients about this, specifically because there's a lot of confusion around live vaccines and immunosuppressive drugs and who should take what and when they should take them. So I don't think that this is a conversation that many GIs are having with their patients due to the confusion that I'm seeing in the community.
So, wow. You know, we're not doing a very good job,
Yeah.
Gil. You and I, as gastroenterologists, I think that's an eye opener for me. Eva, you talked a lot about communication and from a physician side, but how can we better get this message across, not only to the physicians, but to the patients as well? What are some tips that you have, some real world tips that you would have?
I think it's taking the time to have the dialogue. And I think in a general way, when patients feel heard, it makes anything you're suggesting safer. And then coupled with the education, I think it helps them, get over whatever it is that is causing the resistance. Understanding the source of their fear. Having the entire team reinforce the same message. I also love the idea of the fair and presenting the information in a less threatening environment and having that informal access to the entire team is great.
Yeah, and so I like the way you phrase that. Listening to our patients and having them be heard also improves, I think, their security, which maybe even from a safety standpoint gets that message across about vaccinations, and to our colleagues too. And then, Baljit, from a PCP, any other real-world tips in terms of vaccinations?
I think, as we said before, checklists are tremendously helpful in helping you stay on track and on top of these issues with patients, and really just starting to make health maintenance vaccinations and other preventative screening part of every single visit with every single patient, and not just saving it for the annual visit, which may be 18 or 24 months down the road rather than 1 year, but really every single visit with the patient. With electronic medical record, it's a little bit easier because it's built right into there. I get a lovely little red letters of H&M standing for health maintenance on my screen, which lets me know that there may be some preventative measures that I need to address for this particular patient. But even in somebody who's working on a paper chart in a community office, again, having that piece of paper just at the front of the chart, which can be updated and specifically made for that individual patient with their specific individual medical conditions, just looking at that at every office visit and making sure all those boxes have been checked off.
Great. And then, so we're hearing a lot of great ideas. Maybe, Gail, I'll give you the final on vaccines, and then we'll kind of move on to another ARS question.
Sure, yeah. I mean, I would say that from a practical standpoint, when you've got a busy practice, you don't necessarily have that much time with every patient coming in. It can be a template, on a template in an EMR, a hard stop, just not move past before you address it. But sometimes, as Eva said, we need to take time to have the dialogue. And so sometimes we'll schedule a whole visit just to address preventive health issues. And that might be an annual visit with a gastroenterologist or a nurse practitioner that can go over the preventive health care issues, including vaccinations, because some patients may want more dialogue around it.
Yeah, and the last point you made is important, and I'm thinking of our colleagues out there listening to us, and again, in maybe a setting that's not a large academic center. Having our healthcare team, our nurse practitioners, our PAs, our nurses even, do a lot of the education. I think that the extenders, if you will, probably often in a way do a better job at health maintenance, or at least a more complete way of getting patients in. So kind of these real world tips I think are really important. So let's move on to the second learning objective, which is how do we implement guideline-based methods for preventive health care and maintenance among patients with IBD. Again, I want to engage all of you in terms of an ARS, a question. So you should see a question on your screen now. How often do you screen your patients with IBD for mental health issues? So please respond now, select one of your questions, and then, Gil, let's move right into this. And, you have Eva sitting next to you, who I'm going to come to in a minute. That's the obvious person to ask the mental health question, right? But let me get your thoughts on these ACG guidelines on overall prevention, not just vaccines, you can talk about other prevention, and then mental health as well.
Sure, yeah. So we touched on the ACG guidelines, which are about preventive care, and I think it sort of speaks to a bigger understanding of approach to people with inflammatory bowel disease as a chronic illness of proactive care. So there's a lot of things that we should be thinking about proactively with our specifics around treating and managing the disease, but there's also proactive care for preventing preventable complications. So in addition to the preventable infections and vaccinations, there are other recommendations in these guidelines. Some of them are around cancer prevention, and many of these are similar to the general adult health guidelines, but with some tweaks and nuances that may be relevant for the IBD population. So for example, women with inflammatory bowel disease, they should be getting their annual cervical cancer screening, particularly women on immunosuppressive therapies who are at higher risk for cervical dysplasia. We should be thinking about screening for skin cancers. For our patients with IBD, which itself may slightly increase the risk, but certainly certain medications may increase the risk, both of melanoma and non-melanoma skin cancers, particularly as people get older. So thinking about advising sun precautions or follow up with a dermatologist for an annual skin check. In addition, some of our patients with Crohn's disease smoke, and we certainly know that smoking and its adverse effects on Crohn's disease can be very impactful in the trajectory of the disease leading to surgery. So advising and remembering to counsel our patients about smoking cessation if they have Crohn's disease. And then when it comes to bone health, many of our patients are at risk for low bone mineral density or osteoporosis and bone fractures, and particularly individuals who have malnutrition, those who have restrictive diets limiting certain micro and macronutrients, as well as people who've been on corticosteroids, which unfortunately is still a significant proportion of our IBD population. These are people specifically who we need to be thinking about screening for osteoporosis with a DEXA scan. And then finally, as you touched on with this question, mental health issues, I think that these guidelines really took it a notch forward by recommending very clearly that we as gastroenterologists should be screening for depression and anxiety in all of our patients with inflammatory bowel disease.
Great. And so there's actually a patient who has a comment on how we're doing, and I don't want to get to Eva, but let's hear the patient. How are we doing around these screening and preventive health?
I believe gastroenterologists are doing a very good job at all about explaining how much IBD can impact your entire life and the fact that it can have a huge impact on the entire body.
I feel like on this one, this is hit and miss. Some gastroenterologists are great about expressing to their patients any kind of linked diseases related to their IBD. However, I do also see some patients on the flip side that have no idea there is anything related to this or could happen down the road.
Great. So very mixed response. On one hand, sounds like we're doing okay, and then the other, this hit or miss. So let's get back to the ARS in terms of how our audience responded in terms of what they're doing in their practices. And I think we see it's kind of all over. So 27% never, 38% sometimes, and then 29% frequently, with 6% always. So mental health is an important issue. Gil mentioned it for IBD patients. We have a patient that I have who really wanted to talk to us about how IBD impacted him. And then Eva, once we hear about Aaron and Aaron's kind of story, I want to get your reflection on what he said. So let's hear from Aaron.
Professionally, being in healthcare, I would have to use the restroom up to 30 times a day. That was impactful on me and my career. Personally, I couldn't enjoy a dinner with my wife. I couldn't enjoy dinner with my family. Road trips were questionable. You know, those are, you had to plan ahead for those things. And the mental wellness piece of it, I could never shut off. If it wasn't the prednisone, or if it wasn't the steroid, it was the constant thought in the back of my mind: am I going to make it to the next rest stop? Am I going to make it to the next room? And it never left my mind.
So Eva, obviously pretty powerful, impacting not just physically, but psychologically. So tell us, what are your thoughts? What did you hear?
Well, I hear two main points here. One is that if we don't ask, we don't know. Often patients who aren't asked don't share how much, and it was interesting to slip mental health, because I think a lot of our patients have mental health that if we don't ask what role is stress playing in your life, how are you doing? Even more generally, I'm always surprised at our home. We ask what are your top 3 problems. Rarely don't we have something psychological not on that list. I think the second thing that's so important and illustrated by the cycle, the brain-gut cycle and the rest stops, is that really inviting our audience to think of the brain as an extra-intestinal organ affected by IBD. And so it can actually make symptoms worse. There's actually studies showing that a dysregulated brain can actually make inflammation itself worse, make patients less responsive to their treatments, but that also it is an organ where we do have interventions that can help reverse the cycle.
So you talked about this extraintestinal manifestation of IBD being the brain. I think we usually think about the skin, the eyes, the joints, maybe even the liver. But this idea of the brain being involved, and you talked about stress, depression, anxiety. So tell us, how common is this in our IBD patients? What are you seeing from the literature?
Unfortunately, very common. In anxiety disorders, generalized anxiety disorder, panic attacks, and actually social anxiety, and often social anxiety linked to the fear of having bowel movements, is very common, 20 to 40% of our IBD population. So again, much higher than community samples. Depression, 30 to 40%. And then also, even though it's not a psychiatric disorder, pain has an emotional component. When pain becomes chronic, it starts reorganizing the brain. And so chronic pain in our patients, so that's pain lasting longer than 3 months, is something, regardless of the cause, that can also benefit from behavioral intervention.
Yeah, so we actually have a patient audio on how they think we're doing in terms of asking about mental health. And you've already heard from the vaccination and the prevention standpoint. We have a long way to go. And unlike Baljit, our PCP colleague here is doing probably a much better job. Let's hear how this patient feels about our screening for mental health.
I believe, in my experience and others that I know, have not been told about some of the mental health challenges that could come from IBD, and it does not appear that this is being addressed in the physician practice.
Gastroenterologists are not utilizing mental health appropriately. I think that this is above all due to a lack of access to mental health providers. Either there is a wait list, they don't take insurance, or they work on a sort of needs basis for underserved communities.
So Eva, we heard access could be a barrier. The stigma of mental health could be a barrier. So what are some of the services that we have for our patients in terms of mental health and opportunities to help our patients?
So it's interesting that the patient started with access to the mental health provider, because I think the first level of access has to be when you come into your GI appointment, is there somebody asking you the question at least informally? And we know that using validated questionnaires actually is much more sensitive and specific to picking up areas that can be addressed. So I think really looking at who's part of your medical practice, your medical clinical provider team, and is there a way, again, screening for anxiety, depression doesn't take 20, 30 minutes. It is a 2 to 5 minute process. And then I think that if you do not have the resources in your program, being available with a list of crisis service lines, providers in the community. And yep, that takes some upfront homework, and you have to update those lists about every 3 to 6 months, because as the patient alluded to, mental health provider availability changes. But I think that the important thing is there are steps to take. And then obviously, if you do have that ability to have a behavioral health provider co-located in the clinic, I think that's the strongest model. But then if not co-located, easily accessible. And I think now in the advent of increased use of behavioral health technology, we now have much more access in terms of getting psychologists, other kinds of therapists, and psychiatrists by telemedicine means. Obviously, you have to know what the regulations are in your state. Some health systems have regulations around that. But I think the days are over where we can use that as an excuse as providers.
Right.
Now, patients can still have problems, but hopefully then the patient that we heard from would feel comfortable enough with her GI team to go back and say, hey, I tried, I couldn't get in touch, I couldn't get in with that provider, what else can I do? And we have a solution for her.
No, I think that's important. And I think, you mentioned tools, not only from digital behavioral screening tools, I want to get to in a minute, but Bhavjit, you said something to you that caught me. I realized the front line often for mental health isn't the gastroenterologist, but it's the primary care doctor. For the community physician out there, provider, the nurse practitioner, the PA who's listening right now, what are kind of the tips that you have? Patient comes in obviously stressed, depressed. How do you do? How do you engage them around that? What do you ask them, and then what do you take as the next step? And then Eva, I want to come back to some of the screening tools you mentioned.
So as a primary care internist, I wish I'd done more in terms of psychiatric care, orthopedic care, and rashes as a resident, since we see so much of that in the primary care office. And certainly, we know 30 to 40% of adult Americans will suffer an episode of major depression in their lifetime. So mental health is a huge issue in this country. And again, we often will screen many of our patients, if not all of our patients, when they come into the office with some simple questionnaires to see whether or not they might be at risk for depression and/or anxiety. But I think to your point, to the patient's point, once you've done that process, once you've done the screening, once you identify that there may be an issue, as a primary care provider, you may not be able to treat that condition right there in your office, but you certainly have to have the resources available for the patient then to be able to access, or for you to access for the patient to get them to the level of service and care that they need, to have them see a mental health specialist, just like you would have them see a GI specialist as well. We're certainly fortunate enough in our practices to have behavioral health specialists embedded and available to us. So with a phone call or a consult, we can reach out to them and have them contact the patient and get them into local resources. But for instance, you could even contact the United Way. United Way in many communities has available lists of resources and services for mental health for patients, and they can be a point of access for patients as well. So it doesn't have to be something that's just specifically available right there in your office.
Good. And
I'd also actually add to that there are things that even in a busy primary care office you can do. So if you screen, there's a problem, you can have some discussions about medications to use. Your team, even your nurses, can be trained in what I call simple mental health first aid. So problem solving, patients that are negative, even giving them some tips of how can you help reframe, wow, negative thinking really affects your body, your gut negatively. Behavioral inactivation, you're sitting on the couch, you're not exercising. Exercise actually, in several studies, is a very effective tool against, both if you have depression and preventing depression. So I think that it's so important that there are things either in a primary care or a gastroenterologist office, even if you don't have any mental health professional on the horizon, that can be done. Now they have to be tracked. You have to, if you start a psychotropic medication, an antidepressant, you need to have somebody follow up on your patient 1 to 3 months later.
Yeah, no,
but that's easy to build in.
And I think that's great. I mean, this is really important that you don't have to have a super specialized group to do this. And so, Eva, let me hear, maybe just very briefly, because I think the tools are less important than how we will look at this, but just very briefly touch on what are the tools we have for mental health screening.
Absolutely. So I think to your point, it is less important what you use. It's to use something that has been validated, and most of the tools out there have been. As an example, for anxiety, the GAD-7 is used. It's basically the criteria for a generalized anxiety disorder in a 7-symptom checklist, but actually has great sensitivity for every other anxiety disorder in terms of picking up panic disorder, picking up social anxiety. So it's a useful tool. You can have actually a shorter version, the first 2 questions, if time is really brief. And then for depression too, there's a number of different options. The PHQ-9, I think we'd heard about that, is most commonly used. Again, it's the 9 symptoms that you can choose from to get the diagnosis of major depression. I think we have a whole battery of PROMIS, patient report instruments from the NIH, very well validated, tested in huge trials of patients to be very valid. And actually we have them for mental health, we have them for GI, so functional scales. And I think the nice thing for depression with the PROMIS instrument is it's even briefer. They even have a 4-item version, and it focuses on the mood and the cognitive symptoms of depression. So sometimes clinicians, when you're dealing with something like IBD, where if you have activation of inflammation, you're going to have more neurovegetative symptoms like fatigue and sleep disturbance. And so this type of screen gets right at the cognitive emotional directly.
So it sounds like some of these tools can be simplified. And Gil, I'm curious what you're using. You mentioned shorter versions, but then Eva, I want to come back to you in terms of the interventions and what we can actually do. But what are you using in your clinic, Gil?
Well, our organization requires we do a PHQ-2 test. So it's just 2 questions that the nurse addresses with the patient as part of every intake that then gets alerted to the provider if there's an abnormal score on that very simple basic screen. And I think that it's important to understand as somebody who sees a lot of patients with inflammatory bowel disease, sometimes we kind of get used to hearing these stories, and then we get used to it and it becomes normalized. Somebody with 5, 10 or more bowel movements per day, like we heard from your patient, what does that mean to them in their life, their ability to go out for dinner with their family, their ability to work? What is nighttime like for them in terms of incontinence? The impact that the symptoms that we hear about all the time become normal to us, and we don't necessarily take it to the next step of understanding what the impact is to their quality of life. Whether it's a validated screening tool that picks it up, or us understanding that this patient's disease is really impacting their quality of life in a significant way, we need to get them some help. And understanding that is part of the process.
No, thank you. And I think you've emphasized that, and this is something that we have to incorporate into our medical homes, into our topics of treatment. So Eva, I want to move to pain in the next segment, but 30 seconds, which is probably not fair to give a psychiatrist 30 seconds on how we do this, but what are some quick interventions we can do?
Absolutely. So behavioral interventions are the most validated and the easiest to apply, even with medical team members. So cognitive behavioral therapy, a fancy name for teaching patients coping skills to change how they think and what they're doing behaviorally. Hypnosis, meditation techniques. And the beautiful thing with, again, health technology is that many of these interventions now are becoming available as downloadable apps, as apps that even come with coaching that's integrated. And I think, of course, you have to do due diligence to pick ones that have been in the market. And about 5 years is, if something has lasted 5 years, it's likely the real deal and it's going to last in terms of the many products out there. I think they should have published, validated studies. And then I think the last part is medications are useful, but I think the medical professionals, the gastroenterologists, the nurses, can do a lot in how they frame these agents to patients. So this isn't going to cure your anxiety or depression. It's going to dampen your symptoms enough so it's easier for you to learn the coping skills. But no medication that I know to date has taught coping skills. And so I think that's an important message. And then obviously the team approach allows all of this information to be reinforced, not just by the behavioral specialist, who sometimes doesn't have the most sort of value in the team in terms of the ultimate authority. It really is the gastroenterologist and the extenders of the gastroenterologist. When they say something, it often lands in a different way.
No, I think this multimodality approach cannot be stressed enough, not to use the word stress in our patients, but I think that's really good. So let's move to pain. And I think pain's another important issue for our patients. About 20% of our patients will be in what we consider a complete remission, yet they have pain. And we need to figure out how we measure and how we do a better job with pain. So let me switch gears a little bit and go to Gil on some of the pain scale, but then some of the AGA guidelines on pain. Let's start with the scale, this kind of visual analog scale. Talk to us about that.
Sure. Well, we do use a visual analog scale. It's very simple, number line, 0 through 10 scale for patients to tell us how much pain they're in. And this is ubiquitous in hospitals. We use it also in an ambulatory care setting that gives us a very quick snapshot before walking into the room, what to expect when and what to bring up in discussion with the patient. But there are also other instruments that are available, validated promise measures, as Eva mentioned earlier, and other ways of formally assessing pain.
Yeah, and I think pain now, probably any physician visit anywhere now, that's one of the first questions asked in the office, regardless of who you see. So I think we're very aware about this. And then I guess, Gil, you've done a lot of work in terms of looking at pain and IBD, but what are some of the AGA guidelines? And then, Baljit, I want to talk to you about opioids, which is kind of the elephant in the living room now nationally. Sure. But tell us some of the guidelines toward pain, Gil, and how we should think about this.
Yeah, well, pain is a complex topic. As gastroenterologists, we're trained to think of pain as a warning sign for something really bad happening or about to happen to a patient. So somebody with Crohn's disease who's got pain, I need to think, is this a bowel obstruction or an impending bowel obstruction? Is this a flare of their IBD? Is this a penetrating complication or perforation? Some of that is taken by history. If it's accompanied by acute symptoms, diarrhea or abdominal distension, vomiting, etc., of course it takes me in one direction. But to really be thinking about trying to distinguish in my mind as I'm listening to the story, what is driving that patient's pain? And there are things that I can do, tests that we can order to clarify, is this inflammatory pain? We can get inflammatory biomarkers, endoscopy, cross-sectional imaging. But if not, or if we don't think that's appropriate, to think about other potentially treatable causes of pain like bacterial overgrowth, diet-related factors, and to think about opportunities to offer management tricks to patients, such as behavioral therapy, changes in their diet, assessment for bacterial overgrowth with accompanying perhaps antibiotics or changes in their diet, as well as anticholinergics, which may help with abdominal spasm-associated pain. So really trying to understand the cause of the pain is critical, not just accepting that it's an individual who may have chronic pain with exacerbations, to try to get at the bottom of it.
Yeah, and I think it's interesting you brought up the guidelines, and I didn't hear you use the word opioids, which is great.
I was saving that for Baljit.
But I also think the way we've approached pain in the last 20 years has changed. I mean, it used to be narcotic pain prescription would be one of the first things we would give. But so Baljit, talk to us a little bit about some of the CDC's thoughts on pain, but also opioids specifically.
Sure. So obviously, out of the concerns for the opioid issues across the country that we've had over the last number of years, the CDC in the last few years has come out with some guidelines for physicians in terms of, when to initiate opioid therapy and then how to manage it once you've started. First and foremost, I think it's really thinking about the initiation of therapy and making sure that you've exhausted all of your non-opioid pharmacological therapy as well as your non-pharmacological therapies in terms of managing pain with your patients. So we've certainly talked about particularly some of the non-pharmacological aspects already in this discussion. If you reach the point where the decision is made that opioid therapy is appropriate, recognizing that it's often that short-term acute opioid prescription that leads to more long-term opioid therapy and then opioid misuse and addiction. And so we have to be very careful in what we do. We always recommend to start with the lowest dose possible and consider starting with the shortest duration possible, and certainly avoiding long-acting opioid therapy, particularly at the onset. Once you've got somebody initiated on therapy, I think then you have to be very careful in terms of ongoing monitoring. Continue to check with the patient to see, is opioid therapy still indicated and appropriate, or might you be able to get the patient off opioids and other therapies? And if not, as you maintain opioid therapy, make sure that you're watching for signs of potentially either misuse or diversion of opioids, which would then require discontinuing opioid therapy for that patient.
Yeah. So go ahead. Gil.
Yeah, I think just to pick up on that, I think as a gastroenterology group, we have decided in our practice not to prescribe opioids, and that's become a policy for ours. And if we think our patient may need chronic pain management with opioids, we will involve a pain specialist with appropriate contracts with the patient, appropriate follow-up, as you said, because it's hard for us with all the other things that we're doing to keep track of that. And we found that, at least for our own practice, that's been a strategy that we've taken, because we found that, if you don't if we don't take that approach, or until we took that approach, sometimes it's so easy to just perpetuate a narcotic prescription. Patient calls with pain, but you see in the chart that they've had chronic pain, to prescribe them another month or many refills of opioid pills. And recognizing it, certainly with a greater public awareness of the dangers of that, we've taken that approach.
Yeah, so I think I'm hearing from both of you that one, probably prescribing narcotic opioids for pain is something we shouldn't do. Two is, if there truly is an acute need, patient has surgery, patient breaks their leg, that we use short-acting, less than 72 hours. I think, Baljit, your point about not prescribing long-term. But then when we look at unplanned care and patients going to the emergency room and getting maybe opioids in the emergency room, which is getting better now, but still this kind of seeking of opioids, I think we need to be careful. So with that, let's transition into this third objective, or learning objective, and now discuss how we should employ successful approaches to coordinated patient-centered care with IBD, including this concept of a medical home. And here are the things I believe are some of the key ingredients for a successful medical home. The specialist in our medical homes, our IBD medical homes, not as much the primary care, the way it's been set up in the past, but really having the specialist act as that principal care provider. We already talked about incorporating our psychiatrists, psychologists, social workers, the kind of secret sauce of these medical homes, integrating psychosocial care, pain. We mentioned pain already. And then looking at the physician champion. I think all of us practice in a way that we like to take care of these chronic patients. We're involved in these, but without really a physician champion. And I'd actually go a step further. I don't think it has to only be a physician. I think there are many nurse practitioners out there, physicians assistants out there in communities that do a really good job, and maybe not even call it a medical home, but they're doing medical home care for our patients. And then finally, the payer has to be part of this. So working on these new alternative payment models, contracts, the insurance companies, obviously this whole value-based proposition, which I think is really key. So Eva, who when you think about your medical home in Pittsburgh, who are the team members, who are the players, if you will, that work in your medical home?
So the players that are physically present at the office visit each time, we have a devoted scheduler, and really our schedulers are first line and also can be very effective in engaging patients and being available as that resource that they know is always there. We have nurse practitioners, a social worker. I'm the psychiatrist in the home. I happen to be co-director, but I think that in many situations that's not feasible. So I think certainly in the community, having a psychiatric consultant, so somebody, and if you don't have anybody identified, finding one and starting to train them by sending them your IBD patients, they'll learn quickly. So all of these team members, and I think if you have the availability to be co-located, the amount of care coordination and communication and ability in real time to reinforce each other's messages so that the patient has now heard the same 3 or 4 points for their comprehensive care from 4 or 5 different people is very powerful. I think the other part of the medical home, and we talked about access, but I think it's access not just to behavioral health, but ways that patients can access every member of the team. So we actually have morning slots reserved for the patients that we were able to divert from the emergency room the night before so that they can come right in and see us. We have the entire team available and able to provide telemed services, so video sessions to patients. So all of these things I think can have an additive effect in making this team accessible, the care coordination, and then being able to make our patients, ultimately that's who matters, that's who is at the center of the home, make them feel held.
Right. Yeah, and I think the access is key. Why do patients go to the emergency room? A lot of times it's, I can't get into my practitioner, my physician, whoever it may be. And Gil, I know at Cedars-Sinai you may not call it a medical home, but you work in this integrated team model. Tell us your experience. Who's involved in your team?
Yeah, so we do have a dietitian and a social worker who try to see all of our patients when they're there. They try to slip in between. It's not a scheduled visit, but when the patient's waiting for the physician to walk in, they'll slip themselves in, and a dietitian can do a quick nutritional assessment in just a few minutes. And if there are issues identified, to schedule that patient to come back for a later dedicated nutrition appointment. Same with the social worker. Do a real quick screen, do a real quick assessment, get to know you, understand what the issues may or may not be, and then, if necessary, to escalate it for appropriate referral and therapy. In addition, we have opportunities to work in our four walls with a surgeon for J-pouch issues, with an OBGYN for fertility and pregnancy issues. But again, they don't necessarily need to be, and we work with many specialists who are familiar with how to care with IBD-specific issues within the context of our greater healthcare environment. Because we share an EMR, we have the ability to communicate. We have each other's cell phones, which is really important, by the way,
right.
And communicate effectively.
Yeah, so I think communication, access, it's interesting, all of you brought up dietitians at some point. Number one questions patients ask are, what should I eat? What caused this? Diet. So I want to talk about some of our dietitian and also the role of the pharmacist in the medical home. But we talk about the different medicines and the opioids and those types of things. So maybe we can hear from Anna Bondar, is our pharmacist, Cleveland Clinic, and talk about the role of the pharmacist in the care of patients with IBD. What's the role of the pharmacist in the community and community practices? How should the physicians or providers in the community look to work with pharmacists?
So what we always say is drugs don't work in patients who don't take them. So even though now we have some of the best treatment for inflammatory bowel disease, if the patient's not going to be adherent to it, not going to pick it up from the pharmacy due to cost, then what benefit is the patient gaining from a theoretical treatment? So the pharmacist is uniquely positioned to make sure that therapy is actually being taken, that it's affordable, that the patient's being monitored appropriately, that they know what to expect from treatment, and so they actually stay on the therapy and get better.
Great. So, Baljit, maybe I can have you just briefly comment on the role of the pharmacist in your practice and from the community standpoint.
Sure. We're certainly fortunate enough in our practice to have pharmacists embedded in the primary care office, where they can see patients, for the few minutes before the patient is seen by the physician. Often they can do medication reconciliation with the patients, make sure the patients understand what they're taking and why they're taking it and how they're supposed to take it. And that type of education can be incredibly important. We can try treating diseases all we want as physicians, but to the point of the pharmacist, unless they're taking the medications as they're supposed to, it may not be very helpful. They can certainly do pill counts to make sure there's medication compliance and help with issues around pre-authorization as well. We also talked earlier about mental health issues and pharmacists being involved with that in terms of looking at the mental health medications that patients are taking, the potentials for drug-drug interactions with those medications, and again, helping provide more education and awareness for the patients.
Yeah, no, so I think that's a lot. I mean, with all these new medicines, drug-drug interactions, adherence, pre-authorizations, which is an enormous amount of time.
Right.
Now I do want to move to the dietitian and the role of diet and IBD. And what I'd like to do is hear from our dietitian at Cleveland Clinic, who sees patients with me. She often will stay with the patient after I leave the room. Gil mentioned sometimes slipping in between visits. And often I find sometimes the patient comes in to talk about the diet more than anything else. So let's hear from Stacy, who's our dietitian at Cleveland Clinic, and her experience in the medical home. What's the take-home points for the community physician or provider seeing a Crohn's or colitis patient from a dietitian standpoint?
I think a lot of times patients don't make their way to a dietitian until they're malnourished, until we're thinking tube feeding, TPN, those kind of big nutrition support, big life changes for a patient. So I would recommend get a dietitian involved early. So if you're seeing somebody with a new diagnosis of ulcerative colitis or Crohn's disease, there are community dietitians all over, and to get one involved as soon as possible.
Yeah, so the dietitian doesn't only have to be in one of our integrated practices. In the community, there are dietitians. So we've been building this team through the last part of this program, this medical home. And Eva, I want to hear the experience of the medical home on outcomes and some of what you've seen in Pittsburgh at UPMC. around the effectiveness, if you will, of the medical home in your patients?
Absolutely. So, I think you heard about the team members, including we also have a dietitian nutritionist who's part of the team visit. And that combined team, actually, we've tracked our patients now over 4 years. We have seen sustainable reductions in depression, in their quality of life improving. We have seen their IBD severity with the measures we use improve. And then importantly, we've also seen that translated to less unplanned ER visits or unplanned care and in unplanned admissions. And I think the key to that success, we've talked about access, we've talked about communication, the team being available, being integrated, but I think it's also smart resource utilization. So what that means is you need a way, and now we all have access to big data and we're able to mine our medical records in different ways. So using that information wisely, translating that to some easy way that you can use in the clinic in real time. In our clinic, to achieve these results, we actually have created a complexity grid. It takes into account biological complexity, the IBD complexity, their mental health behavioral complexity, but also very importantly, their social factor. So if a patient becomes homeless or they can't afford the food that the nutritionist is recommending, your plan isn't going to go anywhere. They can't afford the copay for the medications.
Right.
And so I think that having a way you take a lot of data that we can now all have access to, translating it in a way, and then last but not least, tracking over time, both the patient's progress and then if they are not progressing in the right direction across these domains, how are you going to pivot your plan quickly to make sure that you do get the resources there?
Yeah, and it's great that we're seeing, you've shown improvement in quality of life, decrease in unplanned care, that ER visits, hospitalizations go down. And Balajit, as we think about medical homes in this kind of what we consider now modern era, I'm sure in a few years we won't feel modern anymore, but how are you implementing electronic medical records and digital apps, and how are you connecting? What's been your experience? I know you've done a lot with that.
Yeah, so I think the electronic medical record has really given us opportunities to connect with patients in ways that we really didn't have before. And with the electronic medical record system that we use, we have the ability to communicate with patients in an asynchronous fashion through MyChart. Patients can send us a question on a non-urgent, non-emergent basis, which we may get to later in the day and respond back. And it allows actually a back and forth dialogue with those patients around that question. Sometimes that leads to the need to actually talk to the patient. That may not necessarily necessitate an in-office face-to-face visit. So we're also developing the capability for virtual visits as well, where online we can get on with the patient, talk to them through a Skype type process, and really get a better understanding of what might be going on and what we need to do to help address their concerns. Sometimes that might lead to a face-to-face office visit with me, but oftentimes it leads to additional questions which I now need help from a specialist from. And we've now also developed the eConsult platform where I can now send an electronic consult question to any one of my specialty colleagues and get an answer within 24 hours from them, either giving guidance on what to recommend or to do for the patient at that time, or perhaps now this has reached a level where that patient actually needs to go in for a face-to-face with the specialty physician. But often along that pathway, we can actually take care of the patient without having them have to take the time out of their day, away from their family, get a babysitter, take time off of work to come in for an office visit just to answer a simple question that we can now manage electronically.
Yeah, and so I like what we're building at Cleveland Clinic, this medical neighborhood, and a lot of this is scaling and connecting over this digital platform. So let me switch gears to another digital tool that we've been looking at, and it's called PAC Health Coaching. And actually I should mention, as part of this CME program, the CME Outfitters has partnered with PAC Health, now offering 100 of your patients this IBD digital health coaching for 3 months at no cost. We're certainly not endorsing this. There are a lot of different programs out there, But this digital health product is actually something that CME Outfitters is using and offering to patients. So a link is available on the Gastroenterology Hub to help get your patients enrolled if so interested. Here's some of the data that's actually been shown with this digital health coaching and how digital health coaching can impact patient outcomes. And you can see improvements in things like medical adherence, less anxiety and depression, as Eva is mentioning, and Gil talking about this engagement in their care. So, you know, we've covered a lot today, and I think that this, to me, is, I've learned a lot from the three of you, and hopefully our audience is learning as well. And I kind of want to pause on some take-home points and go maybe to each one of you to talk about some key take-home points in terms of looking at the community as far as somebody maybe not accessing the medical home and this integrated model. But Gil, some of your key health take-home points from some of the topics you discussed.
Yeah, well, I think as it came up before, a practical suggestion for starting to do this is to create a checklist of some kind. A checklist to help you monitor vaccination status, a checklist to help you monitor your recommendations for cancer screenings, and a checklist to help you monitor bone density assessment. And there are downloadable free checklists that you can print out in pen and paper, and certainly everyone probably knows how to tweak their EMR templates to remind them to do this as part of a scheduled office visit, as one very practical tip for being able to take into your practice tomorrow.
Great. And so these SMART goals around prevention, immunization, vaccination, checklist, screening for osteoporosis, cancer screening, I think you really looked at the whole patient. And then Eva, take-home points in terms of from a mental health perspective.
You know, we talk about patient activation, so hopefully we induce some clinician activation here. And I would challenge the audience to pick one thing that you're not doing. I mean, we saw from the question results that we still don't have enough, you know, every visit, or at least screening a patient every 6 months for the mental health conditions, anxiety, depression. And I'm going to say anxiety, depression because I don't want pain to count. I think, as you pointed out, we all screen for pain very well. And then I think figuring out what is going to be your solution. And you might have to build it over time, step by step. But again, to help the audience become proactive and take whatever they're doing to the next step.
Great. And then Baljit, from a primary care standpoint, these SMART goals we talk about and think about, and take-home points from you.
Yeah. So I think, as we've all discussed today at the table here, it's really about building teams around the patient care. And that's not only just physician teams in terms of a primary care doctor and a specialist, but also our allied health professionals as well, pharmacists, dietitians, behavioral health specialists as well. You know, and we're certainly fortunate at a integrated medical system to be able to have readily access to many of those. As I mentioned, some of them are embedded in our practice. But even if you're in the community, I think there's so much talk and understanding about the need to build teams to take care of patients that many of the allied professionals in the community around you are actually ready and interested in engaging with physicians around taking care of the patients. And I think just reaching out to some of these folks in your community and building those teams can be incredibly helpful and incredibly important to the care of the patient.
Great. So hopefully everybody out there enjoyed the program. Thank you, certainly all of you, for attending. And the program really focused on improving care of our patients. I now want to remind the audience that we created a very useful downloadable resource that includes the slides we presented as well as tools and the full interviews you saw today. The full interviews will also be available as part of the CME Outfitters podcast series. I encourage you to please visit www.cmeoutfitters.com/gastrohub for a comprehensive list of clinical resources, outcome research news, additional educational activities, both for providers and patients, and certainly a whole lot more. And again, thank you for joining us for the presentation of our program, and I ask you to stay with us for this after the show segment. Hope that you'll be able to integrate some of these strategies we talked about today into your practice, into the care of your patients, and we'll be back in 1 minute. Great, so welcome back. We have a number of great questions. We have so many questions. I'm going to ask my colleagues to keep your answers brief so we can hopefully get it through as many of these as possible. So there's a family practitioner that emailed in a question and is seeing an increase in IBD in their patients. So Gil, is this diet? Is this stress? Why is this happening?
We don't know.
Good
It's a combination of all of the above. IBD incidence in the U.S. is pretty stable. It's rising in many third world countries in particular as they become more industrialized. But it may be that we're seeing more recognition, better tools of picking it up, and more appropriate and timely referrals.
Okay. So we don't know is still the answer. Eva, interesting question that somebody has an IBD patient on tofacitinib, but when they screen for depression with MDQ, they are positive for MDD. So maybe you can explain what that is. And then what treatment would you start on that patient on tofacitinib and IBD?
So MDD is major depressive disorder, and MDQ is a major depressive questionnaire screen of some kind. So the short answer is I need a lot more information. I need to know, and my algorithm is active disease, inactive disease. Depression occurred in the context only of disease activity, then I'm much likely to use behavioral techniques first. If there's depression outside of during periods of inactivity, then I'm likely to use antidepressants. Certainly the serotonin reuptake inhibitors, serotonin noradrenergic uptake inhibitors are particularly useful and safe to use in our patients, and particularly for anxiety and depression when it's combined. And then bupropion actually is very useful as an antidepressant if there's fatigue, anhedonia, more neurovegetative symptoms, as long as the patient isn't grossly underweight, because it does have some weight loss associated with it.
And I think one point to make, as far as we know, with really any of our medicines, and tofacitinib was the question, and this is where having a pharmacist would be helpful, but there's no interaction that we know of. So I think that point's well taken. Baljit, can you give an age guideline for HPV vaccine in this population? The questioner's saying only familiar in adolescents. Do we ever give it later in life?
So I think some of the newer guidelines on HPV would actually advocate giving HPV vaccine to patients even a little bit later on in life, in their 20s, and in some studies, and some recommendations from up into their 40s as well. So the guidelines are out there. I think it's getting more less restrictive in terms of the age range that we're advising people to get it, and I would certainly advocate providing it for your patients.
Good.
One point I would make, just to add on to that, is that it's approved for men and women. So men up until age 24 should also be considered for HPV vaccination. Often we don't think about males, but it's something to think about.
Yeah, and I think that's obviously changed from when HPV guidelines initially came out, only females, now both males and females. So Gil, are all patients with IBD immunosuppressed when we think about vaccines?
No.
Okay, I agree with that. As far as influenza, and there are a number of questions on the influenza vaccine, but I'll summarize by saying, what is the ideal time frame for administering the influenza vaccine?
Whenever you see the patient.
Okay, any time of the year?
Any time, well, within flu season, or hopefully early in the flu season. But if you're seeing a patient at any time in the flu season, even towards the end, if they're in front of you, opportunity to talk to them about it and get them vaccinated, especially if you have the ability to do so right then and there. This is a public health guidance really from the highest levels in our country as well as other countries, that the best opportunity to vaccinate patients is when they are right there in front of you.
Okay, now we're going to get really short answers because we're getting even more questions. Sunscreen.
Well, certainly recommended for everybody, obviously. Patients with IBD who may be at more risk for both melanoma as well as non-melanoma skin cancer, certainly recommended highly.
And certainly in IBD, as Gil mentioned, that's important. Gil, patients on anti-TNF, do you use testing, therapeutic drug monitoring, which we really didn't cover? Do you do that proactively, reactively?
I do it reactively in everyone and selectively and proactively with patients for certain medications like infliximab.
Okay, and then similarly on patients on anti-TNF, are there antibody responses to tetanus and pertussis affected by the anti-TNF?
We've actually studied this, and the answer is No, if anti-TNFs are used as monotherapy, but yes, if anti-TNFs are used in combinations with immunomodulators, which by themselves do blunt responses. So that doesn't mean not to give them. We still recommend giving them even in patients on combo therapy.
All right. And continuing along the theme of brief answers, Eva, can telemedicine or telepsychiatry or doc in the box really work in our IBD patients?
Yes, it can work as long as however you're doing it is as integrated as if you had the person co-located. So there still has to be communication. You obviously have to check with the service you're using that they have carefully vetted, qualified providers, and then it's likely going to take some education and again, a communication process offline, team huddles, so to speak, tele-team huddles, to make sure that there's both the education, the coordination, and to the patient, it has to feel seamless.
And Gil, if we can't use opioids in IBD and you need something for pain, what do you use?
That's a tough one. Use acetaminophen, and sometimes benzodiazepines can be effective for pain, but that can be tough. And if somebody has chronic pain, I will usually involve a pain specialist.
All right.
And benzodiazepines with opioids increase the risk for overdose death by 4 to 10-fold. So very careful
as well. Hormones in young women in general, but IBD.
So I think he's talking about estrogen therapy, I'm assuming, of some variety. I think, judiciously, if appropriate, there are some concerns about some of the short and long-term health risks associated with hormonal therapy. So I think you have to really tailor that to the individual patient.
Great. So I want to again thank everybody. I'm sorry there are so many questions. This was outstanding. Thank you everybody for sticking around to the end. We really appreciate your comments. Thank you to CME Outfitters for your assistance in developing this educational activity. And finally, thank you, our audience, our panel, who took the time today to learn about the improvement of care. I'm Dr. Miguel Reguero, and I hope you are all able to incorporate some of our recommendations that we provided into the optimal care of your patients. Thank you, and have a good day.